In a recent study looking at patients who progressed on second-line osimertinib, we see that those patients who all had T790M starting osimertinib can lose T790M. Really, we split into about a third of patients that retain T790M at the time of progression, about 2/3 that lose T790M. If we look at those subsets differently, we can see that the biology is fundamentally distinct. In those that retain T790M, they seem to develop another acquired mutation. About half of those patients will develop C797S. That acquired mutation prevents osimertinib from binding to the ATP cleft and really acts in a very similar way to T790M in the first and second generation drugs. Whereas in tumors that lose T790M, we see a very broad range of different resistance mechanisms. Some of the mechanisms we're familiar with, like amplification of MET, mutations in PI3 kinase, but we see a lot of surprising characters, sort of familiar names, but in unexpected places. KRAS mutations, fusions in RET and BRAF and FGFR3, and some other series fusions in ALK, fusions in NTRK, fusions in ROS. And these are interesting to catch our attention because we have drugs that are potentially actionable, that have some activity against these targets. So can we use that in those settings? And that really is very intriguing, and that work still needs to be done. What's also different about those is really the time it takes to develop that resistance. In tumors that retain T790, the time to treatment discontinuation exceeded a year, whereas in those who lost T790M, they came off osimertinib much quicker, suggesting that in those patients, when T790M was detected, those competing mechanisms of resistance, those clones that had those other alterations were already present. And osimertinib is targeting those sensitive ones, and you have another resistant clone ready to really assume the ranks. That would also suggest that if you detected those early on, that maybe you could tailor your frontline treatment to eliminate those clones, to include those in your initial coverage. So when we think of resistance for EGFR, with better drugs, we thought maybe it would get simpler, but it really is going to get, down the line, actually more complex. But one thing we know for sure is it is going to get better.